Thank you. I must remember that I actually have slides up here as well. I just want to, first of all, again, acknowledge the traditional custodians of the land on which we're meeting today, and those where we work, live and play, and those who are joining us online as well, and pay my respects to elders past and present, and recognise their connection to land and waters, and recognise their contribution to knowledge for all time, and how that shapes and influences the work that we do as well. So, wow, two great presentations that I'm following on from, and it's always really uncomfortable when you're presenting somebody else's work. Whilst this is my PhD student, it's very much his work. But I think it flows on really nicely from the first two presentations, who were really focusing on the adoption of healthier behaviours. And so now I'm just going to turn the tables a little bit and talk about maintenance of behaviour. And anybody who works in behaviour change, which we all do, knows how difficult that actually is. And always. So we, in social marketing, we talk about adoption of behaviours, and we also talk about maintenance, or recognise the importance of maintenance of behaviours as well. And we know that physical activity is really, really important for reducing chronic disease. And I think we've had, numerous examples in this session, but across the whole conference. And I'm sure many of you are working in these types of areas as well. So while adoption is high, when you can get people in, as Claire indicated, sometimes it's very difficult to get people across the line and actually to commence a program as well. Getting them to recognise that they have a need, or allowing them to, find the time for themselves is often a huge barrier. So that's the first step in the process, but then actually getting them to keep up that behaviour once they finish the program or initiative is really, really hard and a big challenge. And that's where Jay's PhD really comes from, and his big overarching research question is about, how do we get people to maintain behaviour? Because once people finish a program, and they're left to their own devices, it's very easy for other things to get in the way. And once those supports that happen within a program are removed, it's really difficult for them to continue on with their behaviour. So there's a whole. So as Jay, has started working on his PhD, he's identified numerous gaps, and these gaps come from, I guess, his supervisors, of which, I am one, our experience, long-term experience in behaviour change, and recognising that this is a really big problem. I guess the first thing that we found problematic as he commenced this systematic literature review was that there's no single definition or no consensus type of definition, and we shouldn't just have one definition, but there's nothing consistent when we're talking about maintenance behaviour. Like, what does that actually mean? And you'll see soon how many papers that Jay, or the team, has actually reviewed, and it's a lot. But there's no consistent definition. So we don't have that real understanding of what it actually takes. So if you don't know what it is, it's really difficult to develop strategies and measures, to help implement it. So, yeah, we don't really understand what the drivers of maintenance behaviour are. And, there's a lot of work done on maintenance of behaviours in health psychology, but, there's definite or distinct and discrete segments within health psychology where they take different approaches. So that in itself, can become very problematic in the approach that you're actually taking or trying to take. Another big issue that we identified is whilst there is a lack of longitudinal studies or studies that actually have follow-up periods, measure at all different time points, and they don't necessarily do it very rigorously. So, if you're a statistician, you know that if you're doing anything longitudinal, you have to take measures at the same time increments, but we don't tend to do that. And it's very difficult, it's costly, it's really difficult to follow up participants as well. So there's a whole host of different barriers. So, some research questions specifically for this study. So, what are the key inflection points in post-intervention behaviour? Which techniques influence these inflection points? What macro or meso factors support behaviour maintenance, and how's physical activity behaviour maintenance conceptualised? So whilst they might look like really simple questions, they're actually not. So the methodology for this particular study, and as you see there are a lot of studies that have been screened, and in this particular study 34 are included. Jay's PhD actually includes 3 different components of the systematic, or 3 different systematic literature reviews, but all drawing from the same database. The outcomes are so varied, the approaches are so varied, the theories are so varied that they can't fit into one piece of work. So, a single study. So there's actually 3 studies, which all have different research questions as well. And it's analysed using R, so with the time points and population characteristics. And it's been a big job. This has been a couple of years with quite a decent team working on the analysis as well. With that sheer volume of studies, it's huge. And that when he first started, we were actually looking at nutrition behaviours and physical activity, but it was actually physically impossible to do that in a PhD. It just returned too many papers. So we've had to, scope the study down several times to make it somewhat manageable. Hence, it still has 3 separate studies. It's really rich, and the implications will be really strong, but it's been a big, big project. I'm really not good at driving this thing. So, what were some of the key findings? Physical activity peaks at about 75 days, and then it declines by 200 days. So you can see that real peak, and then it drops off. I don't think that this is, a particularly, insightful finding, because I think this is what we know. It just puts some numbers around it. The younger groups show better outcomes, and I think, the 2 studies that have gone before me this morning have really, highlighted some of the issues that we have as we get older, particularly when we've got young children. There's other things that are actually more important to people. Goal setting, social support, motivational interviewing, which Claire touched on, My Health for Life, which I like to say I've had a fair bit to do with the development of that program and then the evaluation. And part of that program is motivational interviewing, so it's using adult learning principles as well. So, a really good, strong, rigorous behaviour change approach, and also financial incentives as well. And then in-person delivery, surprisingly, is shown to be the most effective, with physical mail, good old-fashioned post, the least effective. So just in thinking about the theoretical contributions, one of the strongest findings that we had, as I alluded to before, is we need very different strategies for maintenance behaviour to adoption of behaviour. So it's, somewhat difficult to get people to adopt a behaviour, but to get them to maintain that behaviour, we actually need to adopt different strategies to enable people to do that. And the behavioural techniques, or the behaviour change techniques we use, have to align with those real world situations. We heard about the different time constraints this morning as barriers, so we really need to be thinking about those things as well. we hear quite often how, education's really important, knowledge is really important, awareness is really important. Yes, all of those things are really important, and we often base our programs based on that assumption. However, they're not, thinking that people need to know about behaviours, but they already do know that. They recognise that. We also have an assumption that people will want to participate and keep participating in our programs because everybody knows that you need to be healthy. Everybody wants to be healthy. Yeah, sure, but we have lots and lots of research, including all of the early work for My Health for Life as an example, the consumer research that showed people know they need to be healthy, they want to do that, but it's not the most important thing. The most important thing to them is actually getting to spend time with their mates and with their family. And depending on the age group as well, that might be their children, getting to participate in, with their children, watching sport, or as they move into becoming grandparents, being able to participate in their grandchildren's life, whether that's playing, supporting them, or it could be, in the case of men, that they get to go to the footy on Friday night and have a beer with their mates down at the pub. So it's really understanding those things, and they need to be taken into consideration when we're talking about maintenance behaviour. And this piece of work that Jay has done really adds replicable synthesis, and evidence of that, to evaluate mechanisms of action. So, we all know, in here about, leverage points, mechanisms of action, mechanisms for behaviour change, but there's also mechanisms for maintenance as well. So really having a good understanding of what they actually are, because they're the points in the system where we can intervene and actually make change. So, implications for practice and policy. So, practitioners can use, or will be able to use the findings to improve their community-based physical activity initiatives. The use of local infrastructure and social networks boosts sustainability. So actually taking place-based approaches, like Claire was talking about this morning, actually helps people to maintain their behaviour. So understanding, what infrastructure's there, is there safe physical activity spaces? Is it safe to walk? Have they got footpaths? Can that, how far away does everybody live from the supermarket and the schools? Can they walk there or ride their bikes? Or have they got a big, busy highway that divides them so that they can't do that safely? It's thinking about all of those things as we develop our initiatives. Insights can inform policies aligned with national chronic disease frameworks as well. They can also influence local, policy at a local level as well. So, whether that's infrastructure that supports people to participate. Belinda talked about, their place-based approaches to support people. Just ensuring that people have a safe place to live goes a long way to helping them participate and maintain physical activity behaviour, as an example. So just in conclusion, behaviour maintenance is really complex, but it's essential for impact. We really need to understand it. This study identifies promising techniques and critical timelines. I know I've given you a vague overview of those at the moment because they're not all finalised yet. It's a big piece of work to do all of that thematic analysis, and it supports evidence-based practice and policy for lasting healthy change, which I guess is one of the most important contributions of the study, that actually provides some of those actionable insights that are evidence-based, so that we can develop evidence-informed behaviour maintenance programs and initiatives. And I've moved away from saying programs as well, because I'll use My Health for Life again. It started in 2017, it's still going in 2025. So it's moved from being a program to being a service. So it's more of an initiative that feeds into a bigger network of programs and initiatives across the state of Queensland. So when we're talking about maintenance behaviour, we really need to be thinking beyond just programs. And thank you for your time and engagement.
Sorry, this might be a bit technical, but I'm just wanting to understand the definition for physical activity that was used in
The self-identification of physical activity in the papers or in the studies, and they use the term physical activity, so that could be a range of different things. Again, another one of those difficult constructs when you're undertaking these types of systematic literature reviews. And I know we heard this yesterday in Krista McGarry's presentation about how there's so many outcomes that we have in all of these types of programs, and they're not, so it's really difficult to do meta-analysis on them. Randomised control trials are really easy because they have one outcome that they're measuring, so everybody does it the same, it's defined the same way. But in behaviour change, we assign all different meanings to the outcomes, and they're not specific. It's really difficult, and we have to get better at doing that. But yeah, they were self-identified as physical activity is part of is the inclusion criteria.
I was just thinking from like a policy perspective, from like New South Wales stuff, like what do you mean someone's exercising 30 minutes? Like is it against the Australian standard guidelines?
Yeah, and because this is an international study, it's just self-identified as physical activity. Yeah, we've done other studies that we use the Australian guidelines, and that's our benchmark. In Queensland, we're really fortunate as well. We have our Chief Health Officer, that's what they're called, the CHO, does a report every couple of years, and they use the same metrics, so it's actually really easy to benchmark against. But other areas, jurisdictions, whether in Australia or elsewhere, don't necessarily do that. So a lot of my work, we always draw on the Queensland CHO report. Claire?
I'm wondering if there's any learnings that could come out of this piece of work around a lot of programs or initiatives or activities that people sign up to. They market themselves as for a defined period of time.
Mm-hmm.
So 10 weeks to 10Ks kind of thing. And they don't build maintenance as much into that program, and people choose to do it because it seems a quick fix or a fast way to be active. So I'm just wondering how they kind of go against each other if we're trying to get people to maintain that activity level, but so much of what they're being told is get in, do it quickly, and you'll be done.
Yeah, good question. Different study, not presenting today, but yes, we actually are looking at that because you're exactly right. 8-week challenge, 12-week challenge, whatever you like to call it, there is no, follow-up. It's that you're going to lose, 10K or 10, whatever, 5 kilograms, 10 kilograms, 3 inches or, 10 centimetres off your waist in this period of time. And even if they do, we have looked at when they do follow up for that, it drops off really quickly. So they're different paper, but definitely we are investigating those correlations, I guess, between that and then programs that are more longitudinal in their very nature.